Okay, so acid-base imbalances. This is very, very important in order to balance the acidity and the alkalinity of the blood, basically. So we have different things that's very important in order for us to understand this. So I'm going to go ahead and start with a small video first, and then we'll get into details after that. So let me share another video with you. So hang in there. All right. You guys see a video?
Yes.
All right, let's go ahead and start.
pH is an indicator of acidity. The body's blood pH is strictly regulated within a narrow range between 7.35 and 7.45. This is because even a minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism therefore constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms: elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to the blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because, unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles. Pathologic changes may cause acid-base disturbances. Acidosis refers to a process that causes increased acidity, while alkalosis refers to one that causes increased alkalinity. It's not uncommon for a patient to have several processes going on at once, some of them in opposite directions. The resulting plasma pH may be normal. too acidic, called acidemia, or too basic, called alkalemia. Acidosis may result from inadequate function of the lungs, which causes arterial carbon dioxide to accumulate. This is respiratory acidosis. On the other hand, metabolic acidosis may result from excessive production of metabolic acids, ingestion of acids, decreased ability of the kidneys to excrete acids, or loss of alkali. Metabolic acidosis is characterized by primary decrease in plasma bicarbonate. Alkalosis can also be either respiratory or metabolic. Respiratory alkalosis is caused by increased ventilation, resulting in excessive exhalation of carbon dioxide. Metabolic alkalosis can result from excess loss of acids through the kidneys or gastrointestinal tract, bicarbonate retention, or ingestion of alkali. Metabolic alkalosis is characterized by primary increase in plasma bicarbonate. Thank you for watching. Please feel free to suggest a topic you want us to cover.
Okay, so so from that short video, that give you a small, brief type of introduction to the acid base and how our it's very important to balance what we call the pH of the body in general and specifically the blood. So because acidity can really harm the body, and alkalinity also can harm the body, so we need to balance things out. So the the pH is very, very important to be balanced. So how is it balanced in the body is through what we call buffering systems. So the buffering system is to balance mainly the pH to bring it into the middle range, which is 7.4. So anything that is lower than 7.4, you go into the acid side, where anything higher than 7.4, you go into the alkalinity, which becomes more basic. So we need to keep everything within the range of around 7.4. We'll talk about the pH in a second here. But how does it, so the pH is the detector for the amount of hydrogen protons that we have in our body. So this hydrogen here is the main thing that we look at. And that's what the pH measures. And there are different ways to balance this hydrogen here. So these are referred to as buffers. So these are the three main buffers that we look at to balance things out here. We have the bicarbonate buffer system. We have also, it belongs to what we call chemical buffers. So we have the chemical buffers, we have the respiratory system buffer, and then we have the renal system buffering system. So these are the three systems that buffers basically the pH or the hydrogen, balance in the body. So when we deal with chemical buffers, we're dealing with bicarbonate, which is the most common base that we deal with, and with this bicarbonate, it's a base, so we balance the acidity with it. So if we add more base, we're gonna balance the acidity and bring it back to normal again. So so here's how this bicarbonate is produced, usually from what we call carbonic acid. So this H2CO3 is referred to as carbonic acid. Carbonic acid breaks down into a hydrogen proton and a bicarbonate. There's an enzyme that's called carbonic anhydrase. This is the one that kind of plays a major role in breaking this down. So we have this breaking down, and then we produce bicarbonate this way. Also, this reaction can happen in the blood, and then we produce also bicarbonate. Now there is a ratio, so in the interstitial and also in the blood. That's where we're going with that. Every 20, in our system we have like a ratio of 20 bicarbonate to 1 carbonic acid. So this is carbonic acid right here, and this is bicarbonate. So we always have a ratio of 1 to 20. So we have 20 of this and to the ratio of 1 of this. So there's another chemical in our body that buffers, that is called phosphate buffer, okay? So here's the phosphate buffer, which is right over here. So a phosphate buffer always, you know, you have it actually attracting a hydrogen. So it'll take a hydrogen here. So and then it creates an acid. And this acid could be excreted in the urine. So this is another system that we can use in our body to get rid of some of the hydrogens if we need to. So this is the bicarbonate buffer here, okay? And that's the carbonic anhydrase here, which is the enzyme that changes this to this. And it also changes this to this also, it goes backwards. So, so from carbonic acid, we can create, we can go in that direction here, okay? Or we can go in this direction here. So if we go from here to here, we create H2O and CO2. This has a lot to do with your lungs. So let's look at this here. So that's your bicarbonate buffer system. So this is carbonic acid right here. So if we go in this direction here, what we're going to create is CO2 from here, and H2O. So we take one O from here and the H2, and we create water. This is what happens in your lungs, and that's how you produce CO2. So CO2 comes out, and then you breathe it out. Now, in the other direction, if we go from here to here in the kidneys, we can go from here to here, where we break down this carbonic acid into a hydrogen and bicarbonate, okay? And now we're producing bicarbonate, and that is a base that can balance this thing here, okay? So these two systems, the lungs and the kidneys, plays a major role in balancing the acidity of the blood. The other, so the other chemical that we have in our body is called the protein buffer. Proteins are made out of amino acids, okay? So amino acids, which are over here, they could be going into a cell, you know, like in this case, it's a hepatocell. And with the help of bicarbonate, it can break down into two hydrogens and a urea. Urea is the waste. So proteins, we can excrete some of the, you know, NH2 here, okay, that can come out and be excreted. So that's another type of system that we can balance the hydrogen ions in our body. So chemical buffers, all these four here, or actually three, you know, this is just in the blood of the bicarbonate, and this is in the interstitial. And then we have the respiratory system, and then we have the renal system. So all these things here kind of balances the pH. All right, so let's go ahead and look at the normal levels of the different factors that we have to look at in order to balance the pH in our blood, okay? And, you know, first of all, these are very important values that you need to remember by heart. And many of the questions will come and they don't give you these numbers. So you have to know them by heart in order to keep going. So here, you know, we'll look at the other oxygen in a second here, the free oxygen, which is 80 to 100, but this is the saturated one here. But anyways, the pH, so the pH measures what again? What does the pH measure?
Levels of acidity or base?
Yes, acidity or alkalinity. So it's the amount of hydrogen that you have. So the amount of protons that you have, because the H itself measures the acidity. How acidic is the blood? We want it to be in the middle. So the pH, the range, we need this range to be in here. Okay, so 7.35 to 7.45. But 7.4 is the mid-range right there. So 7.4 is the good number. Anything below 7.4, if it's within 7.35, that is fine. It's within normal range, but it's moving down into the acid side. Anything above 7.4 up to 7.45, it becomes more alkaline or basic, but it's still within the normal range. Anything way above 7.45, then it becomes basic or alkaline. Anything below 7.35 will become acidic. So this range right there is normal, but the perfect number is what? 7.4. All right, for carbon dioxide, you need to remember that 35 to 45 is the number here. Now this is easy to remember because you look at this here, it says 7.35 to 7.55. Just take these two numbers here and put them right there. So the pH 7.35 to 7.45, CO2 35 to 45, that's excellent right there. All right, the next thing is, so anything above 7.4, anything above 45 would be what? Acidic, okay? Because usually the hydrogen will come and go along with the CO2 to form, you know, the carbonic acid. So carbonic acid, so every time you look at this here, you think of it as an acid. It's not an acid, it's a gas, but you look at it as an acid. So when I can increase this, I increase the acidity. So anything above 45 would be acidic. Anything below 35 is alkaline, basic. All right, the next thing we look at is the HCO3 here. The HCO3 is the bicarbonate. Now this is the detector for base. So if the higher this number is, the more basic we are. The lower the HCO3, the more acidic we are, okay? So 22 to 26 again is the range. But we know that anything higher than 26 will become what? More alkaline. Anything below 22 will become what? Acidic. So by knowing this, it'll be simpler for you to understand which side is acidic and which side is basic, if it's higher than this or lower than this with the bicarbonate. So which one detects the acid, basically, this one? Which one detects the base? This one. Now the PO2 and the O2 saturation, these two numbers are important, but they're not very much important in balancing the acid base. But you need to be within range. So PO2 is the free oxygen that we have in our body. So your free molecules of oxygen running around in the blood should be between 80 to 100. Although the O2 saturation, that is the one that is basically saturated on the hemoglobin. Usually you want it to be between 95 and 100. And that's what you measure usually with the dexameter. Okay, so far we understand that in order for us to come and interpret the blood gas, arterial blood gases, that's what ABG stands for. So many of you will be working on the floor and the doctor will order an ABG on someone. When they order an ABG, automatically they're checking basically the blood acidity along with the oxygen level in the blood. So they're looking for the pH, they're looking for the CO2, and we call it PCO2 because it's actually a pressure of the gas inside the arteries. Now all this is arterial, it's not venous at all. So when you do what we call arterial blood gas, you take a blood sample from the artery, not the vein. So in this case, again, so these are the steps to come and detect or determine what is the problem with the patient. So you need to look at this chart very well and understand it very well in order to understand how to solve problems, you know, acid-based problems. So step one, you're going to look at the pH. So by looking at the pH of the ABGs, so here are your ABGs. We say pH, CO2, HCO3. Now, again, the O2 is fine and the O2 saturation is fine, but what are the main ones? 1, 2, and 3. So you look at the pH. 7.4 we said is the midline, which is right over here. Between 7.3, okay, up to 7.39 is basically acidic or acidotic, we call it, because it's just a little bit below 7.4. Okay, anything below 7.3 is referred to as acidic. Okay, now why do I want you to remember this? This is important later on when we do some problems. This way we can determine if we have acidosis or we have alkalosis in the patient, even though they have a normal range of pH. Understood? So anything below 7.35 is what? Acidic. Anything above 7.45 is basic. but we still 7.4 is what you need to remember. Anything below that up to 7.35 is acidic. Between 7.4 to 7.45, that would be basic, alkalonic, or basic. For the PCO2, we need to look at the PCO2 level, which is over here. We said 35 to 45 is normal. Anything higher than that, and remember, CO2 determines what? The acidity, how acidic. So when you have higher than 45, then it's acidic. Lower than 35, it's basic. So usually when it's higher than CO2, now CO2 determines the lung. HCO3, which is this one here, determines the kidney. So this is referred to as metabolic, and this is referred to as respiratory. So what regulates the CO2? Your breathing. You breathe the CO2 out. What regulates the HCO3? Your kidneys. It excretes it or reabsorbs it, basically. It reabsorbs HCO3, takes it back to the blood, okay? So, so when we look at CO2, we're talking about respiratory. So if we have increase or decrease of CO2, okay, then you're talking about respiratory. So increased CO2, we said the higher CO2 becomes acidic, and it's CO2, so it's respiratory. The opposite here. If you have a reduction in PaCO2, then it becomes alkalosis. And it's because we're talking about CO2, we're dealing with respiratory in this case again. Now, check the HCO3. If this HCO3 is higher, it becomes metabolic, so let's put this down here just to make sure that we are good. It increases. When it increases, we become metabolic alkalosis. When it decreases, we have what we call metabolic acidosis. Now, this one here, now we have to determine first if it's respiratory or metabolic. Now, respiratory, if it's respiratory acidosis, again, it has to do with what? PCO2, but the HCO3 is normal usually. If the HCO3 is normal and the PCO2 is high, we know that this has to do with respiratory, so it's respiratory acidosis. This one is normal. Now later on, we're gonna learn how when we compensate, this thing kind of changes the numbers, and then we're compensating here. The patient is compensating to this issue here. If you have respiratory alkalosis, then the PCO2 is down. When the PCO2 is down, I said it's more alkalonic, alkalosis. So in this case, it's because we're dealing with PCO2, it's respiratory. Now let's say the PCO2 is normal. If the PCO2 is normal, and this is where the issue is, which is HCO3, right away, you know it's metabolic. If HCO3 is down, we know it's acidotic. If HCO3 is up, we know it's alkalosis. Okay. The next thing we have to look at is the compensation. Patients compensate for these abnormalities here. How do they do this? Is by either breathing out some CO2 or reabsorbing bicarbonate. So when you reabsorb bicarbonate, you make things basic. When you breathe out CO2, you get rid of the CO2 to balance things out inside you. So if you want to get rid of CO2, of acid, you breathe it out. If you want to retain and become basic, you retain the HCO3 within your blood, and then you move into the basic. So here's the story. You could be fully compensated if I go ahead. Now, I need you to remember one thing, by the way. In order to compensate things, usually these two, they move in one direction. So PCO2 goes up, HCO3 goes up also to balance things out. If the PCO2 comes down, the HCO3 comes down to balance things out, okay? So it's just a matter of going in the same direction. I want you to remember that these guys, in order to balance things out, they move in the same direction, okay? The same thing here. So in order for me to compensate, I'm moving these guys in the same direction, up or down, depending on the situation. Now, how can I tell if it's fully compensated or partially compensated? I'm gonna look at the pH range, okay? If the pH range is within normal range, that means it's fully compensated. If it's not within the normal range, if it's below 7.35 or above 7.45, then it's partially compensated, but things are moving very, very close to the normal range. So we look at the pH, it's very close to the, to the normal, which is 7.4, okay? And that then it becomes what we call partially compensated, okay? All right, we'll have some problems here, and then we can play around with it. At the end, we go ahead and look at the PO2 and the saturation here. This is very important for you to know if you're hypoxemic or not. So the patient can come to you, and then you look at them. If their PO2 is low, okay, which is, what did we say, 80 to 100, then they are hypoxemic. Okay, now we can have more than 100 if you put them on oxygen therapy. If you increase the amount of oxygen therapy there, it could go above 100, but well, it gets to the 100 morning. It gets to the 100. When it gets to the 100, that means it's very, very much fully. That's how you increase it actually. It never goes above 100, but you'll know that this is basically how much it is. Now the saturation is how much it's attached to the hemoglobin, basically. Again, if you decrease it, if you decrease the saturated oxygen, then you go into hypoxemia. If you increase it, it doesn't go higher than 100 because that's the majority, that's the maximum that an oxygen can actually attach to a hemoglobin. All right. Go ahead. Why don't you ask me questions, and then we'll continue, because this is this is a lot to absorb for now. So what are some of the questions that you have?
Dr. J, so with
Yes.
the compensation, I always thought like they both had to be on the extreme. pH.
Compensation has to be what?
Like I always thought they always had to be on the opposite side in order to like balance the pH.
Yes, yes, you do. But again, because we're going to look at what we call fully and partially compensated, and in order for you to be fully compensated, the pH has to be within normal range. And if it's partially compensated, that means instead of being 7.35, it will be 7.3 or 7.32. You see how? So if the pH is 7.32, it is not fully compensated. It is partially compensated because we look at the pH, it's very close to 7.3, but it's not fully compensated. In order for you to have fully compensated, you have to have a pH within the normal range, which is 7.35 to 7.45. That's the difference.
Okay, but what does it mean by like it moves in the same direction?
Well, here you go, right there. So look at this here. So if you look here, you see how they're moving in the same direction?
Yeah.
So if you metabolic acidosis, if you have metabolic acidosis, then you know that the issue with what? The issue with bicarbonate. So bicarbonate is low right away. Your PCO2 is going to come down to balance things out. Okay. So these are, they move in the same direction. You see here, they move in the same direction, all of them. Now they are opposite of pH sometimes, okay, but some sometimes they're opposite, sometimes they're the same. So how can you tell if they're opposite? So here's your compensatory mechanism. PCO2 and HCO3 moves in the same direction, right there. See how they move in the same direction? All right. Now pH, we use what we call Rome here. Rome, it means what? In order to tell if the issue that you have goes along or it's same direction as the pH or the opposite direction of the pH, then it says respiratory, opposite of pH. Okay, so respiratory in this case, so here's your respiratory. You look at the respiratory, so if you increase the PCO2, what happened to the pH? It comes down. So respiratory, opposite. Now metabolic acidosis, the same. So if I decrease the HCO3, the pH goes in the same direction. So this is like a mnemonic to remember it, to answer things a little faster.
Okay, thank you.
You're You're welcome. Good questions. Anyone else? Any other questions, you guys? All right, so let's look at that. So you know exactly what we. So if you have metabolic acidosis, metabolic has to do with what? The kidney or the lungs?
Kidneys.
Kidneys. So what do we look at? Do we look at the PCO2 or we look at the HCO3?
HCO3.
So HCO3 here, because it's acidosis, this has to come down, right? Because this is a detector for what? Alkalinity or basic. So it comes down, then in order to balance things out, the PCO2 will come down also in the blood, okay? Because you don't want to have a lot of PCO2 there, then the issue will shift into respiratory issue, you see? So you're just balancing things out here. The lung will balance things out. Let me try and see if you decrease the PCO2 with the lung, what do? You hyperventilate or you hypoventilate to decrease the CO2 in the blood?
Hyperventilate?
Hyperventilate. So when I hyperventilate, I get the CO2 out. So that's how the lung will compensate by hyperventilation in order to balance metabolic acidosis.
Dr. J, I thought
Yes.
hyperventilation was with metabolic alkalosis.
So when you hyper, she said, hyper, you breathe the CO2 out. Hyper.
Oh, okay.
See, when you hyper, you get the CO2 out, so your CO2 decreases kind of. It goes down. Does that make sense? Okay, so now the same issue right over here. Now, you know the hydrogen here exactly goes with the acidosis, the opposite of pH, right? So the pH goes down, you're more hydrogen. The pH comes up, then you have less hydrogen. So acidosis, you have too much hydrogen. Alkalosis, you have less hydrogen. Right? Same thing here. All right, so this is actually a chart that shows you what goes up and what comes down when you are compensated or uncompensated. All right, how can you detect if it's respiratory or metabolic? Again, what do we look at when we say respiratory or metabolic?
The
You wanna say-
PCO2.
Yes, CO2. So here
PCO2.
comes your CO2, exactly. So respiratory, I look at the CO2. So here's your CO2. So the changes will be in the CO2. Now your CO2 here, in order to have acidosis, it's gonna climb up, okay? Then what do I look at? I look at the mechanism, the compensation. Now, again, they go in the same direction, remember? So if I have increase in PCO2, right away you have increase in the bicarb to balance things out. Now, in order to have a fully compensated, you have to have the pH within normal range. And what is the normal range that we said again?
7.35 to 7.45.
7.35 to 7.45, right? Okay.
Mhm.
So if it's within this range, you are fully compensated, okay? All right, now let's do respiratory alkalosis. What do we look at when we say respiratory?
I have a
CO2.
question.
Go
I
ahead,
have
go
a
ahead.
question.
Yes.
So when it's fully compensated, how do
Mhm.
we know if it's respiratory or metabolic if both are changing?
Excellent question, isn't it? All right, so here's you go, here. I'm gonna do this here, even though so 7.4, let's put this range here. Actually, do I have it? Okay, I'll put it down, no problem. All right, here, I'm gonna add this and I'm gonna put this here. All right, now I'm gonna go like this. What comes after below 7 point what? 3.5, 3.4? Okay, how about now? 7 point what? 3.3? Okay. Now what? 7 point what? 3-2. All right, where are we going here? We're going in the direction of what? Acidity or alkalinity?
Acidity.
Acidity.
You see that? Okay, how about now? Okay, move up, move up. Okay, let me just copy and paste here. So if we move up this way, all right, and oh, I'm sorry. This is going to be 36 here. Okay, so 36. Okay, then 37. Okay, which direction am I moving now? Okay, what did I do here? Okay, 7, 7, 3, 6, 7. Okay, 6, 7. All right, and then 8, 7.38. Okay, so what am I doing here? I'm getting close to what?
More basic.
Yeah. You see how? But look at this. 39. Now I go what? 7.4. All right. Now this is perfect, isn't it? So let's say I go up to 7.41. All right. How about 7.42? So what am I doing here? I'm going toward what? Yeah. So as I go up, then I'm getting close to what?
Alkalosis?
All right, so now I'm perfect. What is the middle range right there, right? So, okay, so this is normal. This is perfect, right? Anything in this direction will be what?
Alkalytic.
Mm-hmm. Anything in this direction would be what? More what?
Acidotic.
Acidotic or acidic, okay. So,
Acidotic.
yeah, acidotic. Okay. All right, so do you understand, Betsy? Was that Betsy who asked? So if I give you a pH of 7.4 and I don't tell you anything, right? So right away you think it's what? Alkalosis or acidosis? 7.4 will be what? More what? Toward the alkalosis, isn't it? So it becomes alkalotic. So if you don't have any other detectors, now usually what we do is we look at the case, right? The scenario. But some questions I'm going to give you without that, and that's your answer right there. So if you get just a pH of 7.44, a PCO2 of let's say 22, which is down, right? Then right away, no, let's say normal. Okay. So if I give you a pH of what? pH of 7.4, right? How about PCO2? I'm going to give it to you normal. PCO2 is, let's say, 40. Okay. All right, which is normal. Okay, and HCO3, okay, of 24. All right, now, is this acidotic or alkalotic?
Alkalotic.
Yeah, because you look at the pH here, it's closer to this, even though, so let's say that this is abnormal here. Let's say I have a 60 here, okay? Let's say 50. And I give you here 28. Right. So what do you think this is? Is it more respiratory or is it metabolic?
Respiratory.
And what is it? Acidotic? What is it? Alkalosis or acidosis?
Acidosis.
Okay. So it's alkalotic because this one is what? It's normal. It's normal, but it's toward here. Okay. But is this compensated or not?
Yes.
Yes, it is.
Yes.
So it's fully compensated, but it's more alkalosis, right? Now, usually the one that kind of balance things out a lot more will be the one that we look at. So here, which one is closer to the normal? Is it HCO3 or is it the PCO2?
The HCO3.
HCO3 is closer, so it's more of what? Who's trying to compensate here? The PCO2 is trying to compensate to the HCO3. So this one went up about 10 points, well, 5 points. But this one, usually here, I'm gonna give you this, probably that's even better. If I say 60 and this one here, now right away, you know that this guy was trying to compensate a lot to bring this down to normal almost, you know? But this is gonna be like maybe 24 in this case. Because this is normal, okay? And this is trying to compensate for a metabolic alkalosis by increasing the PCO2 up. Because this is normal, and who's making it normal? This guy. Okay?
So that would be, we said respiratory alkalosis?
This will be actually compensation of the respiratory to the metabolic. Because this one is normal, right? It became normal. And it's when it became normal, okay, originally it was up, and this is compensating for this, because this is back to normal. And who brought this back to normal? This guy, because you bring that up. Okay, let's do this one at a time, okay, because this way we're jumping all the way up to the end here. Okay, we'll do some more problems as we go on. All right, let's go down here a little bit here. So what is fully compensated? That means, again, you are within what? Within normal range. How about if you are so if respiratory acidosis, this goes up, right? Then you know you're within respiratory acidosis. If this one comes down and this one comes down, and with the normal range, then what is it again? It's what? Respiratory alkalosis. Okay. So let's say, how about partially? Look at partially. What happens here? So this one up to balance things out, but this one is the one that was up first. Okay. And then we have this balancing things out. And when this balances things out, then we have the pH, which is lower than what? 7.4. That's how you can tell if it's partially or complete. Right. We'll go ahead and do some problems as we go on, and then we'll understand it a little bit more. All right. What does uncompensated means?
One of
Isn't
the other ones aren't changing to try to bring the other, like PCO2 isn't changing to bring HCO3 down or anything.
Right, right. So if this goes up, it's respiratory. Now, if there's no change in here, then it's uncompensated. And that's exactly what I was trying to do here. It's uncompensated because this one is within normal range. You see that? But this is more normal though. This has to be acidic in order to have respiratory acidosis. So this has to be what, 7 maybe? All right. So this is respiratory acidosis uncompensated. So it's acid, respiratory, caused by respiratory. This is not moving, this is normal. So it's uncompensated. Now, how do we compensate this? We move this up, right? So if I tell you this is like 35, then it's fully compensated now because it moved up with this to compensate. Now, is it fully compensated or partially now?
Partially.
Partially, why?
Because the pH is not in the normal range.
Good job. How about if I put down 4?
Then it'd be fully compensated.
Fully compensated. See, everybody's within balance, fully compensated. All right. Now, if I didn't give you anything at all, and I gave you a 7.442, no, 37. If it's 3.7 here and you don't know what's going on here, right? You have this and you have this. How can you tell if it's alkalosis or acidosis? Okay.
Wouldn't it be acidosis because it's closer to the acidotic
Yes,
pH?
absolutely. Now, usually when you don't get numbers, you're not going to have like almost even increase in numbers. Usually you're going to have one that is lower than the other. And the one that is freaking out, okay, is the one that's trying to compensate for the other. Freaking out, that means it's way above, you see? So this guy is way above this one. So this guy is trying to compensate for this guy, you see? So the original is this, and this guy is trying, so it's what? It's acid, it's, you know, it's within range, but it's more of what? Acidotic, and it's metabolic acidosis, with this trying to compensate. So you look at these numbers. So if I have a 30, that's even a bit better here. This one is 45 is the normal, the highest. It's going up to 60. Because it's going all the way up to 60, that means, and this is like almost, you know, it's high also with the base, okay? But this one is more of normal, so it's compensated. But what is it, you know, partially compensated what? Metabolic.
Acidosis?
Well, you know, this is higher than 26, so it's alkalosis. What's the normal range for HCO3? 22 to 26. So this is higher, so alkalosis. And by doing this alkalosis, then automatically this is going to go up to balance things out. Okay?
So to tell like if it's respiratory or metabolic, you basically just look like which one is much higher, because that means it's trying to compensate.
Yes, the one that's with the higher number wants to compensate for the other guy. That's why it's freaking out. It's going off a little bit more. If you're not giving any other things, you know, if you're not giving like usually here, this thing here, a patient is hypoventilating here, okay, to balance this out, the alkalosis, because you're retaining CO2 here to balance for this alkalosis. So the case will say patient is hypoventilating, you know, that had some kind of kidney issue, diabetic coma and all that stuff. And then you know that there's alkalosis going on, and then this one is compensating for this.
Okay.
So, so here's again, so uncompensated, you have no change in the pH. No change in the PC. Okay, so this is so straightforward, easy to know if it's acidosis or alkalosis. What would that be? Looking at what?
The pH.
Yeah. So look at the pH, up or down. If we want to detect respiratory from metabolic, what do we look at?
CO2 and HCO3.
Yeah, PCO2. No, if we want, well, you know, PCO2 respiratory, and then PCO3, HCO3 would be metabolic. Yes. So, so what is uncompensated means? There's no shift in the other one, right? There's no shift. That means it's uncompensated.
So Dr. J, I had a question about that.
Yeah.
So when you say no change in like the bicarb or the carbon dioxide, could it also be true that that those two things are within the normal range?
It is usually you could be in normal range, but usually yeah. I mean, it could be in normal range and didn't go up or down like accordingly. So it didn't compensate at all. It just stayed within normal range.
Okay.
Yeah.
Okay.
You see, you want to bring it back to normal in order to compensate. If it's not moving at all, then you know, so it's not within normal range, then it's uncompensated, which is right over here. So this is a chart that kind of puts you together here. So here's your respiratory acidosis. Okay. If it's uncompensated, what's happening? So your pH is down, your PCO2 is up. what's happening to the HCO3? No change. So within normal range. Yes, within normal range. Now, partially compensated, what would that be? The pH is lower, right, than 7.35. And we know it's respiratory because the CO2 is up. Now, partially compensated, the HCO3 will go up again also, along with it. So these two guys will go up together to compensate, but the pH is lower than 7.35. Closer though. Not way off, right? Not way off. Because it's 7.32 or 7.3. Because if it's within normal range, then it becomes what? Fully compensated. So if we deal with respiratory issues, usually you have issues with breathing. So always respiratory acidosis, if you are unable to breathe out the CO2, you have respiratory acidosis. So these are disorders where you retain CO2 in this case. All right. So asthma, you retain CO2. Pneumonia, you retain CO2. Hypoventilation, you retain CO2. So as soon as you get a case with respiratory issues, you know that it is respiratory without even looking. Now, unless if they're telling you that they have, you know, kidney issues and diabetes and all that, and the patient started hyperventilating or hypoventilating to compensate, right? Then, so you look at the question and you see what is the history of the patient. If the history of the patient is asthma, pneumonia, and all that, then you're thinking that this guy is having respiratory issues. And then they'll tell you this HCO3, you know, the ABG shows that the HCO3 went up or went down accordingly. Then you know it's trying to compensate or not. So respiratory alkalosis, again, it has something to do. Now, this one, we are getting rid of the CO2 here. Respiratory alkalosis, you're getting rid of the, so hyperventilation will get you to breathe out the CO2. Panic attack, what happened to you when you're panicking?
Hyperventilate.
Yeah, so you're hyperventilating, you're getting the same thing. How about aspirin poisoning? This is tricky, by the way, the aspirin. I'll talk about it in a second, how it's at the beginning, you know, it gives you acidosis because of the, I'm sorry, at the beginning it can give you alkalosis because of the reaction that you're hyperventilating. And then you go into acidosis because aspirin is what? An acid. So we'll look at aspirin in a second here. How about metabolic? So compensated and uncompensated. So if it's uncompensated, what did we say? The pH is down, metabolic. How about, we're going to look now, if it's metabolic, we're going to look at the HCO3. So HCO3 is down. What's happening in CO2? Is it changing at all? It just stays within normal. So if it's going within range and it's not going down like it should, because it should go down along with this in order for it to compensate, right there, the second one. So this one, it goes down, this one goes down, this one goes down with metabolic. Now, partially compensated, it's a little bit below 7.35. Fully compensated is within normal, 7.35 to 7.45 for the pH. And both of these guys goes down together. Metabolic alkalosis, same thing. What do you look at? The pH, and you look at the HCO3. The pH is up, HCO3 is up. What's happening to the CO2? Not changing. And the same thing down here also. So metabolic acidosis, you're retaining, basically you're getting rid of a lot of what? The base is coming out because it has to do with this. So I'm getting rid of the base, so that's why it's shifting down here. And I'm keeping basically, when you get rid of bases, you become acidotic. So what things I can get rid of bases, or I can retain acids. So I can retain acids or get rid of bases. So diabetic ketoacidosis, eventually I become acidotic because of what? Because I am a ketones has carboxylic acid on it, which is an acid. So diabetic ketoacidosis is part of acidotic because I'm keeping acids here. Lactic acidosis with muscles and all that has to do with that too. Retaining acids. Alcohol, okay? Alcoholics, usually you get rid of bases in this case because OH is what? OH is a base, okay? And when you use a base, you balance out the, you create water and you get rid of that, and then eventually it becomes acidotic, your blood. And salicylate is what? Salicylate, we talked about it as aspirin. So this is later on. Later on, you become metabolic acidosis. At the beginning, you become alkalotic. Alkalosis, metabolic alkalosis is the same thing. So alkalosis, when we get rid of acids here, if you vomit the acid out of your stomach, you're going to become alkalotic. If I lose potassium, because I lose potassium, I lose hydrogen, remember hydrogen and potassium kind of thing? So vomiting, diarrhea, the same thing here. Diarrhea, I lose HCO3 more often than acid. When you vomit HCl. Diarrhea, you get rid of the base. So here are the charts here. So, coming up. So this is basically the whole mechanism here, everything we discussed in general by looking at this. So the pH lower, you become acidemia, and then respiratory or metabolic. Respiratory greater than 40 point. I mean, these numbers are okay, but again, we're moving below or higher. They gave a very close number. We use 45, they use 44, that's fine. 22, we use 22. This one is CO2. Again, that's the same thing here, but this is respiratory. This is metabolic and respiratory alkalosis. This is respiratory acidosis, metabolic acidosis. And these are some of the things that would happen in these compensatory mechanisms. So if you have respiratory acidosis, okay, that means your PCO2 is higher than 45 or 44. Right? How can we compensate? Well, the bicarbonate will be reabsorbed by the kidney. So when you do that, you increase the number here. So you increase the HCO3, and then you eliminate hydrogens. That's what the kidney does. It eliminates the hydrogens and it retains this. Okay. Same here. So when you have HCO3 less than 22, respiratory CO2 elimination, you start hyperventilating in this case. And here the same issues. All right, so let's look at the let's look at the respiratory acidosis one by one and look how what are some of the things that are affected by respiratory acidosis. Who wants to go over this for me and see if you guys understand this? Anybody wants? Betsy, you want to start this one, and then we'll go down the line to see. Can you just talk about this? How this is going on? So tell me about the organs that are affected and why, and try and make sense out of it. So.
So respiratory acidosis. So it would be affected, like, because you're unable to, like COPD, you're unable to like breathe out properly, so you're retaining more of the CO2.
Excellent. What else?
Keep going on the organs affected.
Yeah, I mean, acute respiratory distress syndrome, that's again, it's what? You're distressed. So are you retaining CO2
So you're retaining CO2, like
also?
your
Mhm.
so like your breathing is like depressed.
Mhm, mhm. And pneumonia, why are we having issues with pneumonia? Why are we retaining CO2 here? What's pneumonia again?
Fluid in the alveoli.
Yeah, so if you have fluid in alveoli, then how about the exchange of CO2 trying to come out and diffuse out from the blood into the alveoli? If you have fluid in the alveoli, then the CO2 that wants to come from the blood into the alveoli to breathe it out, the water is preventing. Yeah.
So there's no exchange.
Yeah, there's not much exchange, so it stays where? In your blood. So the CO2 stays in the blood, you know. And the same as what? PEP stands for what?
Pulmonary embolism.
Mm-hmm. Yeah, with pulmonary embolism, what's happening here?
So you have a blood clot that's essentially moved into the lungs.
Absolutely.
So blocking.
Mm-hmm. 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 So you have issues. So what do you notice here? It's all what? Respiratory issues, right? So respiratory issues gives you what? Acidosis. That makes sense? So tell me about the mechanisms here. So what's going on here in the clinical manifestation? So what does that mean?
So your respirations are lower, which you're hypoventilating, which means you're not releasing CO2, you're retaining it.
Mm-hmm, mm-hmm. What does capillary diffusion mean? Everybody else can help her out, by the way. You know, I mean, she's the leader, but you know, other people can come and help out if needed. Where does capillary diffusion happen? In this case.
Isn't it the alveoli?
The alveoli?
Yes, yes, the alveoli and the capillaries around the alveoli, right there.
Like gas exchange, like decreased gas exchange?
Yes, yes. So you have less CO2 being exchanged and going into the alveoli. So it's retained in the blood, okay? And that causes a condition that is called what? What is this here? So Betsy, this is what called?
Oh, acidemia.
Acidemia. That means what?
So you're retaining CO2.
And
Excess of
what is this here? H2CO3.
carbonic acid.
Good job. Good job. So this is different than bicarbonate, which is this. Carbonic acid has an extra hydrogen, if you notice. You see that? So an extra hydrogen, it's an acid. So we retain this and we don't switch from here to here, you know? So in this case, look at this. This guy is normal. It's not changing. That's why I have an acidosis. It's not compensating, is it? If this is normal, is it compensating?
No.
It's not.
No.
Just staying the same thing. It's not compensating in this case. So we're going to end up having respiratory acidosis. Now, if this one goes up along with the CO2, then what?
Then it's compensating.
Compensating, right. So this one here, increase PCO2. How about the hydrogen ions?
Increasing.
Have increased. What about the O2, the concentration, PO2 or saturated or unsaturated PO2 is what?
Decreasing.
Decreasing. You know, because compared to the PCO2, it's decreased. So this guy's hyperventilating. You want to give him some oxygen, don't you? Mm-hmm. So you give him some, oxygen to build up things. All right, so the other issue is what? CNS? Stephanie, why don't you tell me about this condition here? What do we have here? Try and explain this if you can.
Like the direct result, is that part?
Yes, yeah, the CNS. So how does the CNS play a role in getting respiratory acidosis here?
So you have a center in the brain, the medulla, that controls breathing rates.
Excellent.
So things like drugs could, like morphines, opioids, those can cause respiratory depression.
Yeah.
So the breathing rate, so causing hypoventilation, and as well would depress the CNS, causing things like drowsiness, dizziness, and disorientation. And then the increase in IPC, I don't know what IPC is.
Anybody can help her out? ICP.
ICP.
Intracranial pressure.
Yes.
Oh, okay. So
Yeah, intracranial pressure. Good job. So what's going on here? What is the intracranial pressure again? Anybody, it doesn't matter.
It's just the pressure based on the volume of fluid in the brain or surrounding the brain and the cranium.
What pressure?
The intracranial pressure. It's between the space of the skull and the brain itself.
Okay. Yes, and now where do we look at intracranial pressure? What causes the usually what's a pressure is? It could be either increase in the pressure itself or the volume of something, right? So in this case, let's say you get increased in the CSF production. Does that give you increase in intracranial pressure?
yes.
Yeah.
See, that's how we look at it. How about increase in the blood volume inside your brain?
Yes.
Can that lead to that? How about a tumor inside? If I have a tumor inside, would that increase the pressure?
Definitely.
Yeah, so these are different types of risk factors that can actually increase the pressure, you know, like Aaron said, within the skull. You know, so the pressure in here, because everything's pushing out and the skull is holding everything in, and that's basically what's causing the whole pressure to increase, okay? All right. Now, what's going on here with decreased sodium and decreased potassium here? How are we looking at that? Anybody can give it a shot here. What can lead to decrease in sodium and decrease in potassium in this case?
Could it be like a diuretic?
Yeah. So would a diuretic increase, you know, would it cause, if you are taking, it depends on the diuretic, of course, right? So carbonic anhydrase, for example, and that's the one that build up H2CO3, and that's, you know, you become basically, you know, acidic by building the H2CO3. And when you have increased increased hydrogen, then automatically you're gonna decrease potassium. So increase hydrogen. So all of these here, when you have acid, you have increase in hydrogen, don't we? So increase in hydrogen can lead to this. See how? So think of it this way: the increase of hydrogen that you have acidity. We know that hydrogen and potassium goes opposite each other, right? We learned that already. So the same thing as for sodium and this one too. So you have, you know, but in the cardiac, you know, dysrhythmia and all that, decreased blood pressure, you know, that's what you can have. So tachycardia, your heart rate increases. What's going to happen to your, why are you having tachycardia here? That's usually what? a reflex, right, reaction to balance things out. So eventually you start having hypoventilating. And when you are hypoventilating, your heart's going to beat faster to compensate. So that's what happened with your heart. So in respiratory acidosis, you are going to end up having tachycardia and dysrhythmia to compensate. And your blood pressure goes down usually after a while to compensate. Again, this is like a compensatory mechanism and the different type of clinical manifestations that you get with these things. This one gives you pale cyanotic because you have increase in what? Increased CO2, right? So when you have increased CO2, you're going to have cyanosis type of skin. All right, neuromuscular here. So neuromuscular, all these guys are retaining actually acid. Okay, so so with these, you can have you can end up having respiratory acidosis sometimes to balance things out. So we know that these are muscles, so they're going to give you muscle weakness in general. And when you're muscle weakness, then you have increase in lactic acid. Okay, so this one here and increase in lactic acid. Let me just so you have increase in lactic acid in this case, and that's how you become acidotic with that type of. This is more of a metabolic than respiratory, but eventually that type of respiratory acidosis eventually also retain CO2. When you retain CO2, you become acidotic, and with these issues, lactic acid is more direct to that. How about mechanical ventilation? When we give you ventilation, that mechanical artificial ventilation, if we slow it down, eventually you're going to do what? You're going to have retaining, so slow down. If I slow down the rate of that respirator or ventilator, then you're going to retain what? CO2, because you're going to hypoventilate. So that's one thing that you can, so you're going to increase the PCO2 in the blood in this case. Post-op, again, respiratory paralysis can lead to increase in PCO2. So when you have your muscles are weak, you're going to retain CO2. Okay. Overweight, so you're not breathing, well, so you're retaining CO2. So you go into acidosis. So respiratory acidosis, mainly it's respiratory, right? And mainly it's these two here. Now the rest could also be affected, okay? Because if you decrease the CO2 in general on your body, then these guys will be affected more. And then you end up having these type of abnormal electrolytes and gases. All right, who wants to talk about respiratory alkalosis? Aaron, you want to do this?
Sure. Okay. So respiratory alkalosis is just pertaining to the fact that you're gaining more of a base due to a respiratory issue. And because CO2 is considered an acid and you're releasing more of it, you're going to actually make it more alkalotic. Mm-hmm. So because of hyperventilation and deep breathing, you're going to get rid of CO2 and lower bicarb. And because when you lower bicarb, you actually it actually makes it more basic. So that's why you have
hold on. So you were reducing the CO2. In order, when we reduce the CO2, who compensates? The HCO3. So it goes down.
Right.
So we're actually, balancing things out. That's why. Because if we increase it way above, then you go off the norm in this case. So, all right, good. What else? So you have increase in breathing.
Basically, while you decrease the amount of CO2, you also compensate by gaining more oxygen. But you need that CO2 to kind of balance things out. So, you know, and you have a decrease in potassium because when you decrease bicarb, you decrease potassium with it. And so that's why that's on there.
Yeah. You know what? I'm gonna do one thing here because it's a little bit confusing because I have this as actually normally. Okay, this is just a mechanism here. So you know, the CO2 goes up to balance this.
Right.
The HCO3 goes up. You're correct. But if it doesn't, you know, with like if this stays, this is compensatory, right? So let me maybe I should take this out so you won't get confused because this is compensatory. Yeah. So this is better now. So in order to have respiratory alkalosis, you have low PCO2 and normal.
Yeah, for I mean for partial
that's
for partial
compensation.
compensation.
To understand. So good.
Yeah. No,
right,
I get that.
Right. Okay,
yeah,
sure.
You have partial compensation right there presented. But if the bicarb were to decrease with the PCO2, it would be fully.
Yeah.
So, but basically, what this is saying that due to a respiratory issue that leads to hyperventilation or increased release of carbon dioxide, you become more basic. And you can take in more oxygen. So, and depending on what the bicarb level is, you know, is whether it's compensated or not.
So the CO2 and the oxygen, they kind of opposite each other. So if I decrease the CO2, the O2 will increase, you know, like level wise, not, you know, of course, you know, you're going to be taking more CO2, okay? Because you're hyperventilating, you know, you're not actually, but the level in the blood ratio, you know, like if we look at this decreasing automatically, this level will go above this because this goes down, this goes up, you see? So it doesn't mean that, you know, but you try to get more oxygen if you can, but ratio wise, this one comes down, this one will be higher comparing to this because this is within normal, this is not normal anymore. So yeah, excellent, good job. What about the muscles here? Again, so we're hyperventilating muscle pain. And what are these things? How are we decreasing lactic acid in this case? So if you exercise, okay, you are, you know, you're flexing, you're hyperflexing your muscles and all that, okay? Do you increase lactic acid or decrease lactic acid when you exercise?
You decrease it?
Decrease it. So we get rid of lactic acid by exercising and hyperflexia. And when you have pain actually in the muscles, okay, now, again, it could be due to increase or decrease, but in this case, we are hyperventilating. So we are actually causing the muscle to work a little bit more. And with that, we decrease the lactic acid, and that's how you become, sorry about this, hold on a second. In this case, we are actually increasing lactic acid, not decreasing. You guys does that make sense with you? Because if we, no, it decreases it. No, I'm fine, yeah. Because if it increases, then we become acidotic, correct? Increased lactic acid makes you acidotic, but in this case, it's alkalosis, so it's decreased. All right, what else do we have here? With the tachycardia, again, compensation, you have decrease in CO2 to compensate. We have increase in the heart rate in order to make you hyperventilate eventually. And then when you hyperventilate, you get rid of the CO2 in this case. All right, so so this is you know, like we said with these things here, we're with aspirin, initial symptoms alkalosis, and then because you end up vomiting, by the way, when you take aspirins and you have aspirin poisoning, the first thing you do is you start having nausea and vomiting. So eventually you lose all that acid in the stomach. So you become alkalotic at the beginning, but later on, because that, you know, salicylic acid goes into your blood and it's an acid, then eventually it, you know, so in this case, only initially you have alkalosis. Later on, you have acidosis.
Is that related to acid rebound?
Yeah, I mean, acid rebound is when you have like an acid episode of an acid later, you know, with time. But here, yeah, I mean, eventually when you take this aspirin and you overdose it, eventually your body will not accept all that acid, and then it just vomit it out because you're going to have extra acid in your stomach than normal. So that's what usually happens in this case. All right, so this is this again very straightforward. You know, you can. The only thing I want you to remember is high altitude also, which cause you to hyperventilate. So when you do that, again, you decrease in these things here. But here you decrease both, actually, not only the CO2, you know, because you're not breathing enough oxygen when you were up there. So you need to remember that. Here also, you know, when you insult your skin, you know, like you burn your skin, again, you lose this, so you hyperventilate because of that. So your CO2 goes down and the oxygen goes down also. You know, so hyperventilation, basically, in this case, that's what's causing the alkalosis. So respiratory alkalosis, the major thing that you need to remember, hyperventilation, respiratory acidosis, you're hypoventilating. So whatever causes you to hypoventilate or hyperventilate will lead to those disorders. That's the basic bottom line. So you look at the question, you look at the history of the patient. If something that they're taking that's going to lead them to hyperventilate, okay, then they're getting rid of the CO2, so they go into alkalosis. If they hypoventilate, then they're retaining CO2 and they're going to acidosis. All right, so metabolic acidosis, metabolic alkalosis, we said it has something to do with what? With the HCO3 in general, okay? And these are problems other than lungs. So when we are dealing with metabolic, don't think about lung issues. So if you look at the question or the scenario of your patient, if they have lung issues, think about respiratory. If they're saying diabetic, ketoacidosis, gastric stuff, renal stuff, you know, all that, you think metabolic. So in this case, we have acidosis. So we have a decrease in HCO3, right? So this one is decreasing, and that's how you think of it. Alkalosis, we have increase in HCO3. Acidosis, we have decrease in HCO3. So that means what? You do not reabsorb more, you know, of this. So you are not actually producing this. So this is produced in the kidney, and if you're into acidosis, you're not producing HCO3. You're just retaining H2CO3. All right, so so decrease elimination of HCO3, decrease bicarbonate level in your blood, or a combination. It could be any of these things here. So what's going on here? The increase in H, you know, again, if you remember, I talked about this, that leads to hyperkalemia, and how hyperkalemia is affected in this case. You guys remember I said, you know, metabolic acidosis can lead to hyperkalemia, and that was the mechanism here. We went over it, because usually what we said, potassium goes up, hydrogen comes down. but in this case, the hydrogen will shift and the potassium will shift out, because when you have acidosis, that means you have too much hydrogens, right, in the blood. You're expecting the potassium to come down and get hypokalemia, but in this case, because of all that acid outside, when it comes inside, the potassium will shift out to balance things out, because a lot of these hydrogens comes in, some of the potassium goes outside and then eventually into the extracellular, and eventually you have hyperkalemia in this case. All right, these patients will breathe in what we call Kussmaul respiration. Kussmaul respiration is basically a very whispering type of breathing where this patient is trying to get the CO2 out. That's what they're trying to do. So they'll breathe like this. They're trying to get, breathe the CO2 out. So that's Kussmaul respiration. So usually this happens with metabolic acidosis. So I want you to relate this to metabolic acidosis. And the reason for this is to try and get that CO2 out. That's why they have this. All right. So again, all these things can lead to metabolic acidosis, including renal failure. So when you have renal failure, you're unable to get rid of the hydrogen out. You are unable to secrete the hydrogen out of the nephrons, and then you're going to end up having acidosis. Again, increased loss of HCO3 also when you are not able to reabsorb. So usually kidneys does what? They reabsorb this guy. So if you have kidney failure, you're not going to be able to reabsorb this. So you're going to end up having acidosis. Now, diabetes mellitus, here's the story. I talked about it before, but let me mention it again. So with diabetes mellitus, eventually, you're trying to get the insulin to increase, okay? Either taking insulin or your body's trying to increase the amount of insulin so you can balance the glucose. So when you do that, your glucose goes down, potassium goes along with glucose. So when you have decreasing glucose, your potassium goes down. They go together. Now, if potassium goes down, you have increase in hydrogen, you have acidosis in this case. Now, diabetic ketoacidosis, ketones, we have extra ketones. When you have extra ketones, it is an acid, and it's made out of carboxylic acid. So when you have extra ketones, you're going to have extra carboxylic acid, and that's acidosis right there. Same thing as alcohol. When you take too much alcohol, you're going to end up having acidosis because of the ketones. Now, severe diarrhea. When you have diarrhea, you lose a lot of HCO3. So eventually, when you lose a lot of CO3, you're going to end up having acidosis. So diarrhea gives you acidosis, decreased bicarbonate because you lose it through from the gut. All right. Also, vomiting. Okay, I don't know what is vomiting. It's not even here. All right, that's fine. We'll look at vomiting in a second here. Starvation, again, it has something to do with glucose, same mechanism as diabetics. Hyperthyroidism, increased thyroid, you increase the metabolism. When you increase the metabolism, you use a lot of sugar, so you have less sugar, you have less potassium, you have increase in hydrogen, so acidosis again. Aspirin, later on we said late drug overdose. After that, you become acidotic because of the carboxylic acid that the aspirin has. Muscle, exercise, strenuous exercise, again, you excrete, strenuous exercise, strenuous exercise eventually will cause this. Not the regular exercise at the beginning, you lose this, but strenuous, you're going to start having muscle soreness because you really overuse the muscles, and then eventually you end up building lactic acid. That's later on if you overuse your muscles so much. So bodybuilders, many times they get pain in their muscle because they're overweight, overusing them. Shock, also increased lactic acid here, and also CO2. You know, not only this, but CO2. You have increase in CO2 with shock. Less oxygen, increased CO2. So let's just bring CO2 down here. Increase CO2. All right, CNS, the same thing, confusion and loss of consciousness can lead to increased acidic lactic acid also. The last part would be metabolic alkalosis. And in this case, again, when you have metabolic alkalosis, we say we have hypokalemia from that. And we looked at, in pharmacology, we understood the mechanism, and that's how we get it. Now, alkalosis, increase in HCO3 in your blood. It is caused, again, by renal issues, endocrine issues. All that can lead to metabolic alkalosis. Increased bicarbonate, you have decreased production of acid, against, increased renal elimination of the acid in this case. Okay, so it could go either way, right? So it could go either way with the kidneys. So it depends on what you get. Here, by the way, vomiting, okay, will get rid of what? The acid, and then you're gonna end up having what? Alkalosis in this case. All right, so diarrhea, think of it as what? Acidosis, and vomiting would cause you alkalosis because you vomit what? The acid. So when you lose the hydrochloric acid and you have severe dehydration also, all right? So when you have severe dehydration, again, you have less hydrogen in your body, and you end up having less hydrogen, so that would cause you into, again, alkalosis. So metabolic alkalosis. Drugs can lead to that also, certain drugs. Again, anything that causes decrease in potassium, decrease in chlorine, okay, like some of the diuretics here, decrease in chloride, then decrease in hydrogen. So this one goes along with hydrogen also. So this one is decrease in hydrogen also. Okay, so it's very simple, straightforward mechanism here by understanding what it is, and that would tell you. So hyperaldosteronism, you have increase in sodium, decrease in chloride, in this case, decrease in hydrogen. Actually, potassium here, decrease in potassium, not here. Do this here. Increase in potassium. Increase. All right, that's fine. Let's leave it here for now. That's fine. Either way, HCl goes together in a pump. All right, diseases that cause loss of potassium. All this can lead to loss of potassium. So when you sit down, you can actually. Let's look at some questions here. And now tomorrow I will have a tutoring to solve problems. So we'll do all kind of acid-based problems if you show up to 1 o'clock to 1 o'clock tutoring, okay? But let's do one here. So here, this is straightforward. The person is having cosmorespiration. What do you think it is, we said?
Metabolic acidosis.
Yeah, so right away, this is a compensation for this. So that's just an easy question there to answer. So here, but look at the history here. Person arrives in the emergency room department, consciousness, up this. The individual have a history of diabetes. So right away, when I say diabetes and diarrhea and vomiting and all that, that has to be with what? Metabolic, right? So right away, it's metabolic. So you rule out the first two, and then either alkalosis or acidosis, but we know this is respiration to retain carbon CO2, so it's metabolic acidosis. All right, this is straightforward here. History of chronic lung disease. As soon as they tell you lung disease, what do you think of? Respiratory, right? Of productive cough, hypoventilation, headache. the nurse suspect what? Now, hypoventilation is what? Acidosis or alkalosis?
Acidosis.
Yeah, so respiratory what? Acidosis. Very easy, isn't it? Okay, let's do this one, which is a problem. So, you know, forget about the answer here, but look at the question. A patient states that they have been vomiting. All right, when we say vomiting, what do we right away say? Metabolic or respiratory?
Metabolic.
Metabolic.
Okay, metabolic. For the last 4 days, the patient is irritable, weak, reporting muscle cramping and weakness. On assessment, the patient is experiencing bradypnea with respiratory rate of 10. Now, respiratory rate of 10, is that normal? What's the breathing rate?
12 to 20.
12 to 20, right? So 12 to 18 or so. So 12 to 20. So 10 is bradypnea. That's what they have. The patient has the following ABGs. Look at this. HCO3. Okay, now we already thought of what? Metabolic here because of the history. Now we want to say, is it metabolic acidosis or alkalosis? So what's the simplest way to look at? The pH, right? So what's the pH here? 7.52. Is that acidic or basic?
That's base.
That's basic. All right. So it's metabolic alkalosis, correct? Now let's look at these two. So this one here is 36. All right. And this one here is 48. All right. 48. What is the normal thing here? What is the normal PCO2? Up to what?
45.
45. So when I give you 48, all right, is it compensating?
Yes.
Yes, it is. So it is compensating. Now, what about the pH? Is that within normal range?
No.
So it's compensating, but it's not within normal range. So the answer is what? Metabolic alkalosis is partially compensating. Does that make sense?
Yeah.
All right, good. So now, of course, we're going to do a bunch. Now, I gave you on your focus points a bunch of questions to do with histories and without histories. We will go over them tomorrow. Okay? So we'll go over them and I'll give you more problems to make sure that you know. So today, go ahead and review this and see if you can make sense out of this. And when you come at 1 o'clock tomorrow, we will go over the problems and we'll try and solve the acid-base type of problems.
Dr. J?
Sounds good, you guys? Yes, sir.
For our tutoring, I remember the course saying something we're going to probably a longer than normal class because apparently we have a speaker coming in, which could run till 1. So is it possible to be like 1:30 just in case it does run over? I do remember her saying that.
Absolutely. So, okay. Now, we can, you want to start at 2 instead?
Or for me.
Or you're going to tell me, maybe one person. I mean, I can leave it at 1. And if you stick around longer, what do you guys think? You want me to move it to 2 to be safe or?
Yes.
Yeah, I agree with the 2. I agree with the 2 just in case the speaker runs over.
Okay, so let me move it at 2. I'll adjust it 2 o'clock instead. Okay, and then we'll meet at 2 to 4. We'll make it 2 to 4 or whatever needed to get going, okay? So be prepared to solve problems yourself. So I'll be asking you to go ahead and do a problem and explain it, why you have the answer for that. But you probably have a very good idea how to do things now. And it's not that, complicated. If you just follow the instructions that I went over with, we should be good. Any questions, you guys? Any other questions? All right, fantastic. Okay, sounds good. So I will see you later on today.
Thank you.
You're welcome.
Thank you, Dr. J.
You're welcome, my friend.
Thank you.
You're welcome.